Hello everyone, here is Abdul Qadir, emergency medicine specialist. Before discussing about the EFAST, extended focus assessment with sonographic in trauma, let's have a very quick and short review on the basic ultrasound and physics of ultrasound. It's very important to be familiar. Otherwise, we cannot adjust the seating to have high quality images with good resolution. And in these cases, if you don't do adjustment properly, there is chance of misinterpretation, there is chance of missing some pathologic things, and we will face with lots of artifacts. So it's very important to adjust the ultrasound properly. There is some elements that before studying any ultrasound examination we should adjust them. One of them is the depth. So in which depth you wanna to find something, what is the location, what is the anatomical location that you wanna look at it. So for example, if you wanted to see to have a look in the kidney, so depth should be higher, more like 15 centimeter. So it is in depth, it's retroperitoneal. But if you wanted to check something like superficial in the skin, like superficial abscess, so we don't have that much depth. So maybe 2-3 centimeter, 5 centimeter is enough. So based on the study, we should adjust the depth. Another one is the brightness. So we call gain. So how the image is bright. If it is too dark, we should so increase the gain, means receiving more echoes, more sounds from the organs, from the mediums, and we can visualize pathologic things, the normal finding much better, and we can differentiate the objects from each other. But if it is too dark, you should increase the gain. So based on the brightness, you can increase and decrease the gain. Another one is the focus. So what is the area of interest? For example, if you wanna to check something in 10 centimeter, the focus should be set in 11-12 centimeter. So more focus will go on this area, and you can focus more on that area, and with less artifact and better images with good resolution. And another thing is the probe orientation. Another factor is always we should keep the probe with the marker in the right side, or if you wanted to do like vertical ultrasound exam, like longitudinal view, so we should keep the marker toward the patient's head, and on the screen always the marker should be kept in the right side. It is a very short review, so we need to study more about the ultrasound physics to be more familiar with the knowledge, with the physics, and also in this case you can adjust the machine appropriately, and you can have a better images and interpret in the base. But this course just it's a short review for the basic ultrasound or the nebulology, and also for the EFAST. It doesn't mean everyone that if watch this video will get enough skill properly to do the ultrasound examination. It's just a short review on this subject. So anyone if have interest, so they can book and register in workshops, hands-on workshops, have training, and then they can start to do ultrasound examination under observation, and with the practice we will get more skills, and you can do the ultrasound exam properly. Otherwise, just using the ultrasound maybe sometimes is not safe, as you can interpret something like pathologic, but if it is a normal, or you can miss some pathologic, or just say it is a normal. So this course is not just, it is not for that to get some skill. It just to be familiar with this subject. So let's dive into FAST. So FAST exam is a rapid bedside ultrasound technique that for identify free fluid inside the abdomen or surrounding the heart or detecting pneumothorax. It is just EFAST is for trauma patient, but for detecting free fluid, you can use it in any cases with abdominal pain or suspected to, any intra-abdominal hemorrhagia in any cases like ovarian cyst ruptures, EP ruptures, or any cases with abdominal pain and a stable patient. You can use it to see, yeah, there is free fluid or not. So in these cases, you can activate your team and you can run investigation in appropriate way, on time, without any delay, and inform the related services to get the patient better and high quality care. So if EFAST, if you back to traditional practice, for the lots of trauma patient, they did DPL, diagnostic peritoneal lavage, but right now, thanks for ultrasound, we can use EFAST to detect free fluid. So in these cases, no need to do DPL. And as we discussed, the goal for the ultrasound, like EFAST, is just detecting free fluid. It's not just it is not to detect the organ injury. You want to say, is there free fluid or not? And it is very easy study. You just need to be familiar and do practice, some training, have some training, and doing some case study, just a study under observation, and you will get a skill to do these easy ultrasound examination and help the patient. So no need to transfer the patient to other departments. Sometimes it's not safe to transfer patient to other department as there is potential complication. The patient sometimes they are not stable enough to transfer to another department. So in these cases also we can save the patients, you can save the time. So that's why it's very important to emergency medicine physician to be familiar, to use the ultrasound like for EFAS in trauma cases or in unstable cases. EFAST exam has three components: peritoneal exam, precardial exam, and pneumothorax exam. So we will discuss every component one by one, and what is the technique, what is the pitfalls, and how we can interpret them. So we will start from right upper quadrant. In the right upper quadrant, what organ do we have? So we have diaphragm, we have kidney, and we have liver. So the first space that we should have assessment is the caudal liver edge. So between the interface between liver and inferior kidney pole. The second space is Morrison pouch. It is usually between 7 to 9, or in some patients 10, 11 intercostal spaces. So we check a hepatorenal space for any fluid accumulation. And the third one is suprahepatic area. So it is just you need to perform careful sweeps about the liver. Sometimes the fluid accumulates between the liver and diaphragm. As you see in the picture, there is so how will you should hold the transducer, the probe. It's mid-axillary, posterior mid-axillary, 7 to 9 intercostal spaces, and we keep it like longitudinal or vertical in vertical line, and then we move the probe to up, down, anterior, posterior, and sweep it, tilt it, angulate it to find the kidney, to the liver. So it's very important to keep it the transducer, the probe, just 90 degree over the kidney. So we can just adjust the probe to have the best images as we see in the next slide. So as you see here, there is a lever. It is the Morrison recess, and it is the kidney. It is the spine sign. So this bright is the spine. So the fluid usually accumulates here between the liver and the kidney is a Morrison pouch. Here it's the positive fast. As you see here, there is a hypoecho and echo. Fluid usually shows in hypoecho, or you can say anecho. There is a no echo. It's completely dark. So it's a positive fast. It's the liver edge. It's the kidney. So it is obvious. There is a free fluid here, and it's a positive fast. And here there is a round shape hypo and echo object. So it is not like free fluid. It's something like contained. It is not, free fluid. It is like maybe false positive fast. If you don't familiar with this, image, you may misinterpret as a fluid. But it is a fluid, but it is like a cyst. It is the kidney. It is the kidney cyst. And let's have a look in this image. It is the liver, it is the kidney, and it is the Morrison pouch. And here there is hypodensity. It is renal fat. So sometimes renal fat could be misinterpreted as a free fluid. As a difference, as we discussed, the free fluid should be completely dark without any echo. But sometimes there is some echo, some floating debris inside the free fluid, so it is different. But here there is some echo texture like soft tissue, so it is fat. Here, as you see in this image, it's the liver, it's the kidney, it is the Morrison pouch. It's very, very thin rim here, you can see. So this fast is positive fast, even the rim is very, very thin. But as a trauma patient, so we can say it's a positive fast. So if the patient is stable, so need to do CT scan to find the lesion. And here, as you see, another positive fast. It's the liver, it's the kidney, and it's the free fluid. And this hyperdense object inside the free fluid, it's a clot formation. So already formed a clot in this case. And here is you see, so we discussed that you should check the Morrison pouch. Another one should be suprahepatic between the diaphragm and the liver. Sometimes fluid accumulates here, so we should check also this area to don't miss some mild effusion. And here it is the inferior lobe, inferior pole, kidney pole. We should always check here between the liver, it's a caudal edge, and here sometimes you can find fluid. So it's very important to have a look also in this area. And if you see here, there is some vertical dark lines just obscure the liver, so you cannot see anything here. So in these cases, it is like shadowing of the ribs. You can just tell so they keep it the ultrasound transducer here like vertical. That's why and there is some shadowing. You can ask the patient to take the breath to remove this shadow, or you can tilt the transducer, the probe, like 90 degree, keep it like vertical. So in this image there is no shadowing, so you can easily remove the shadow to have a best and better images to don't miss any free fluid. Another component is the pelvis. So the pelvis we should check in transverse, and also you should do sagittal view. So usually we start with transverse view, point to the pubis symphysis. You should not keep the ultrasound probe in 90 degree. So we should just keep it in the caudal and toward to the pubis symphysis. And in vertical view, we keep the ultrasound like that and tilt it toward the feet, and we will have some such these images. As you see here, there is a bladder, is a female patient, it is the uterus, it's vagina, and it is the bladder. So we search for fluid here, usually posterior to the uterus, or sometimes between the uterus and bladder. As you see here, bladder, uterus, and here the space that we usually look for fluid. Another case is a female patient, as a horizontal view. It is the bladder, it is the uterus, and here there is a free fluid, so it's a positive case. And here it's a vertical view or longitudinal view. It's the bladder, it's the uterus, and here we should search for free fluid if there is any free fluid. And here in another case, the positive, it's a bladder, it's a uterus, and free fluid just behind the uterus, so it's a positive case. And here, as you see, it's a male patient, it is a bladder, it's a prostate, and it's a clean picture, there is no free fluid. Another case, the male, so we have double wall sign, it is the mirror of the bladder, so it is a fluid here outside of the bladder. So in the pelvis, we should search for any fluid outside of the bladder. So it is not normal to have. If the bladder is not full, is empty, you should give some saline to patient, or sometimes it's the emergency case, you should just insert the Foley catheter and fill the bladder with saline, and then repeat the ultrasound to make sure there is no free fluid, because with empty bladder we cannot say there is no free fluid, as sometimes free fluid is very less. So always we should check the bladder in two view, sagittal and transverse. If just you do transverse, so there is chance of missing mild free fluid, so we should check behind the bladder and sweep the transducer to check all the parts of the bladder, from the anterior to posterior and from the right to the left. Just we should sweep until the probe to check every part around the bladder. In other study, so it is the vertical, it is the bladder, and very few fluid here is suspected. Another one, if you see there is free fluid outside the bladder. So another view, it is left upper. Another place we should check in EFAST. So in the left side also we have diaphragm, spleen, and the kidney. We keep the ultrasound probe transducer vertical. Comparing to the right side, to the left kidney is more posterior and more superior. So sometimes it's difficult to find the kidney and splenorenal races. Sometimes it is difficult, and it is more difficult comparing to the right side. But with practice, you can get skill, and you can find the organs. In the left upper quadrant also we have three spaces that we should check. The first one is suprasplenic area between the spleen and diaphragm. Another one, it is splenorenal interface, and another space is the left paracolic gutter, just close to the inferior kidney port. Here, as you see here, it is the spleen, it is a splenorenal space, it's a kidney. Here it is diaphragm, and here it is supraspleen, supraspleen space between the spleen and diaphragm. And here it is the diaphragm, and here it is the mirror sign of the spleen that we can see here, and it is the spine here. It is the positive fast, spleen, free fluid, and the kidney is anechoic fluid here, we can detect. And here it is supra-spleen fluid accumulation. You can easily detect. And here it is inferior pole, the kidney, and that there is no free fluid. So it is the vertical, so they keep the ultrasound in vertical line. So here it's superior, here is inferior, and here, as it is at the left side, it is the left side of patient, and here is the right side of the patient. And here what we can see, just shadowing. So in these cases we cannot interpret. It's inconclusive study. So in this case it's better to just tilt the probe, change the position to just remove the shadowing, the shadow, and here we have a clear images that you can see the splenorenal spaces, and here also it is the inferior pole. So better to have an image always to see the superior and inferior pole in one images if it is possible in both right and the left side to don't miss any free fluid. Another component is precardial effusion. So we don't want to do a proper echo. We just wanted to find the precardium and to see if there is any free fluid outside the precard or not. You can use multiple views, but subcostal or xiphoid view is the best one. And the fluid is like hypoechoic rim or fluid surrounding the heart. You can keep the ultrasound transducer such as this one, like a pen, should not keep 90 degree over the epigastrium, the patient, and should keep it like 15 to 30 degree angle to the abdominal wall. The best approach is that to find the lever firstly, the left loop of the lever. So, and you can use lever window to find the heart, and it is very easily then we can find it as here is the lever, and then we can find the heart. Here it is the right side of the heart, it is the left side of the heart. So if you see, so you can see here free fluid surrounding the heart very easily. It's otherwise free fluid, and this test is positive. Here it's the liver, it's the right side, and it is the left side of the heart. Here, as you see, is a little confusing picture image, but here there is some hypoechoic thing suspected, but here there is no free fluid outside. So free fluid should be detected surrounding the heart. Here it's like fat pad, precardial fat, and as you see here in these images, there is some free fluid surrounding the heart. It is the aorta, it is the heart, and here there is free fluid, and also here there is a free fluid. This free fluid is the posterior to the aorta, so it is not precardial effusion, it is pleural effusion, but here it is just anterior to the aorta, and this one it's precardial effusion. So precardial effusion should be anterior to the aorta, as you see here. So it is left ventricle, left arteria, aorta, it's the precardial effusion as we mentioned before, and here it is the pleural effusion. Another study, it was a trauma case, so we did the precardiocentesis for these cases. It is the precardium, and here there is a clot. So we drain the blood and we transfer the patient to the OT. As we discussed it, so we can use FAST for non-traumatic patient also, any patient with abdominal pain, just to detect free fluid. Sensitivity for hemoperitoneum is 74%, specificity 96%, and less than 5 minutes if you have a good skill, you can finish it. It's not time consuming, and 91% sensitive for pneumothorax. For the pneumothorax, so probe placement is very important. We should identify a pleural line and assess lung sliding. So we divide the chest to 5 parts. In the anterior, one as upper, lower 2, lower chest, and the axillary line 3 and 4, and one here as a just vertebral, and it is the fifth and part. So we should keep the transducer like that, vertical. And the first thing is that, so we should check for line sliding. If you find the line sliding, so it is not pneumothorax. But we should check at least in 5 parts in every side. If there is a no line sliding, we should check for the B line. If you find a B line, so it is not pneumothorax. But if there is a no B line, we should check for long point. If there is a long point, so we will discuss what is the long point, so it is pneumothorax. But if there is a no long point, we should check for long pulse. If there is a no long pulse, it's a pneumothorax. If there is a long pulse, it's atelectasis. So let's check this one. As you see here, there is lung sliding. So if you have a patient, so there is this lung sliding, the pleural line is moving, so it's not pneumothorax. But as we discussed it, we should check at least if is in 5 parts of the chest in every side. I mean, 10 points we should check in the lung, in the right and the left sides. So it is the lung sliding. And here, let's check this one. So for the lung slide, you can use color Doppler. If you use the color, so with moving, you can detect the color. If there is a no lung sliding, so you cannot detect any color. So it's another way to confirm there is a lung sliding. Here, as you see, there is a no lung sliding. There is a movement, but there is a no lung sliding. It's a pneumothorax case. And you can use M mode. So if there is a no lung sliding, use the M mode. We should have C shore sign. It's a C, like a C, and it's a shore. So we should have C shore sign. If you put the M line on the pleural, on the pleuv, and if you see something like that, so here all it's like C, barcode sign, it's a pneumothorax. So if you see C shore, you can see some parts like a C, like shore. So it is the C shore sign, and it is not pneumothorax. But if you see all parts like a barcode sign, there is a no C. In these cases, we called pneumothorax. We diagnosed pneumothorax. Here, what you see here, there is some sliding here, but here still there is no movement. So it is long point. It is very, very specific for pneumothorax. So if you detect lung slide in some part and another part of the pleuv and the same intercostal space, so means the lesion is there and it is the pneumothorax. It is just another picture. Just I just bring here to see the aortic dissection. So how it is important to be familiar with the ultrasound that we can detect life-threatening lesion. Thank you very much for your attention. Please feel free to contact me for any question, and we can discuss and we can enhance our skill together to empower emergency medicine. Thank you.